We're going to go get started just a little bit late here with our afternoon session. Our first speaker is Dr. Mario Spaggiari, who's one of my colleagues at UIC, who is assistant professor of surgery and transplant, and he's going to speak to us about intestinal lengthening, really tapering procedures and their indications and how it's done. Mario?
Okay, so thank you for the opportunity, first of all. And again, yes, I'm an assistant professor and a transplant surgeon at the University of Illinois. And today I had the pleasure to talk to you about indication for bowel lengthening and tapering procedure. Let's see. Yes. Okay, so first of all, I would like to start with the definition of gut failure that I'm pretty sure everybody is pretty familiar with. So gut failure is the loss of nutritional autonomy due to absorptive, obstructive, or motility disorder involving one or more of the abdominal visceral organs. So since the implementation of TPN in 1960, so basically patients with gut failure had a chance of survival. This chance of survival, of course, was just the beginning that led the way for visceral transplantation and for the procedure that I'm going to talk about today. So the autologous gastrointestinal procedure. So about the causes of gut failure and the causes that lead to a potential surgical procedure. So every time, so we know that fluids, nutrients, electrolyte absorption is directly related to the absorptive length of the small intestine. So every time we have a reduction in the mass of enterocyte, of course, because of surgery trauma, I will go in details a little bit in a little bit. So we have a malabsorption. When the length of the remnant bowel is less than approximately 1 meter or 60 centimeter in the presence of a functional ileocolic valve, we can develop what is called a short bowel syndrome, so a severe malabsorption that requires the treatment with total parenteral nutrition. And in terms of causes, of course, the causes may change according to the age of the patient. So in the childhood, usually volvulus, intussusception, trauma are the main causes. In the adult, ischemia, Crohn's disease that of course requires multiple abdominal operation, or volvulus are other causes. And I would like to include also, as a personal experience of our center, the complication of a bariatric procedure. Gastric bypass, for example, that sometimes can lead to intestinal failure due to ischemic problem. And so in terms of management, so we have two types of intervention that we can perform every time we are facing a gut failure condition. So we have intervention that we can perform in the acute phase, so when we try to reestablish the nutritional autonomy of the patient. And then we have intervention that we can perform in a late phase, in the chronic phase, when basically we're going to try to foster the adaptation of the bowel and try either to wean the patient off parenteral nutrition or at least to decrease the amount of parenteral nutrition, and so the chance of developing like a TPN-related complication. And talking about the early stage intervention, well, so first of all, the resolution of infectious sources and the prevention of infection sources is one of the interventions that should be addressed at the beginning. So the relief of obstruction for people who had multiple abdominal surgery, like patients with Crohn's disease, and relief of blind loops, the closure of fistula, and the restoration of the intestinal continuity. It's another, I don't want to say acute, but let's say subacute intervention that we should perform to either restore the absorptive capacity of the bowel or at least to decrease the complication and the volume of TPN. So if you are able to perform this procedure at the right time, in many cases you are able actually to save the bowel. And just to give you some example about this procedure, So second look operation. So when we are talking, for example, about ischemic episode, as we know, the ischemia of the bowel can progress over time even after, the first surgical resection. Sometimes, so a second look operation is able to spare the viable bowel just by resecting the portion of the bowel that is not viable anymore, then preventing the bacterial translocation and sepsis, development of enterocutaneous fistula, and so forth. And other interventions are, for example, the strictureplasty. So these are interventions that we perform when we have strictures, so partial obstruction, for example, in the setting of Crohn's disease, and we want to save the bowel length. In these cases, instead of performing bowel resection, what we can do, for example, in here, so we have a stricture, so we can perform a transversal incision and a side-to-side suturing in order to relieve the stricture. In case of a very angulated loop of bowel, like in this case, so instead of transecting the bowel, we can preserve the function, the loop of bowel, simply by performing a side-to-side anastomosis. And this is another very important topic. So a patient who had trauma or for any reason they develop multiple enterocutaneous fistula, so most of the time they have multiple high output fistulas. Well, in these cases, it's worthy to perform multiple resection, so basically take down all those blind loops that are attached to the skin and perform multiple anastomosis. So basically, we are restoring the continuity of the bowel. And in the best scenario, so this can go towards an adaptation of the bowel, so a weaning off parenteral nutrition. Sometimes we can just decrease the amount of the volume of nutrition required. And talking about the intervention in the late stage, that is pretty much the focus of this topic. Well, so first of all, these procedures that are not very commonly, they're not very common utilized, they should be tailored on the patient condition. We have different variables that we have to take into account. So first of all, the first variable is the length of the bowel, of the remnant bowel. Then how is the transit? So what is the main complication, the main concern, the main symptoms of the patient, the extent of the bowel dilation, and then the overall patient condition. So we talked before about liver disease, portal hypertension in the setting of long-term TPN. Well, this procedure, if performed in a setting of portal hypertension, most of the time they don't work. Portal hypertension is associated with decreased absorption of electrolytes, water, and so forth. And at the same time, portal hypertension leads to the developing of varices and collaterals that makes this procedure very difficult to be performed for pure surgical reason. So these procedures are commonly called autologous gastrointestinal reconstruction procedure. And the first question should be when this procedure should be performed. So as it was mentioned before, so every time we have a bowel resection, so the bowel goes towards a process of adaptation. So adaptation means that enterocyte and crypt cell proliferate, smooth muscle cell go towards hyperplasia, and the adaptation is very subjective, the length, the timing of the adaptation. There are many factors that need to be taken into account, starting from the age of the patient. So younger recipient, usually they have a faster adaptation. Older recipient or older patient or patient with comorbidities, usually they may not have any adaptation, or if they have, maybe not sufficient and takes longer. Usually 2 years is the maximum time to be considered an adaptation. And talking about the impact of this procedure in the panorama of gut failure and intestinal visceral transplantation, So as you can see in this slide, since 1990, so since the development of visceral transplantation, we observe a steady increase in both adults and children of the transplant rate. Then, since about 2008, as you can see, the number of cases progressively decreased. So there may be many factors to justify that, but definitely one of the factors is that we became more familiar with the gut rehabilitation procedure and the medical treatment that in many cases are able to, at least to spare the patient from bowel transplantation. And so going a little bit into details about the procedure. So the first set of procedures are procedures that we perform in people who have watery diarrhea as the main complaint, so very quick transit through the bowel. So the first procedure was described in 1887, and basically what they describe is that by placing a 10 centimeter loop of small bowel in an antiperistaltic way, we're able to delay the transit, increase the absorption, and in 45% of the cases, we have been able to wean the patient off TPN. And in case we have the luxury of have some colon left, some colon spared, well, in this case, another procedure has been described. So we can place a segment of colon of about 10 to 20 centimeters, usually in the proximal portion of the small bowel, in an isoperistaltic way. We know that the colon has the main function is the water absorption, but at the same time, follow-up study performed on the segment of colon showed that the colon goes towards a process of adaptation itself to the point that it starts to resemble from an histologic point of view, the small bowel, and even the contractility of the colon, the function start to resemble the small bowel. And in these cases, we have 65% of patients that were able to be weaned off parenteral nutrition. Then I want to mention this procedure too, that it's pretty much abandoned because it can carry many complications. So it's something that these days, has not been offered to the patient anymore, but for an historical point of view, so in case we have patient with spare colon, but the absence of the ileocecal valve, so with an ileocolonic anastomosis, another procedure to slow down the transit was to recreate an ileocecal valve. So basically to recreate a sort of valve mechanism, a sort of pseudo-obstruction to delay the transit. The way it's done, so basically the ileocolonic anastomosis is taken down, the mucosas of the small bowel is everted as a sort of maturing stoma, and then is tubulized inside the colon. And so to give you a summary of this procedure that we perform when the bowel is not dilated and when the main issue is the watery diarrhea, so the high output diarrhea. So these are procedures that, so the main procedure that we perform is the antiperistaltic segment of small bowel, especially because in cases where we don't have the colon. So the nipple valve placement has been pretty much abandoned because it can lead to progressive intussusception of the bowel, small bowel obstruction, bacterial overgrowth, and many potential complications. And then we move to the next set of procedure that are the procedure that we perform in case of severely dilated bowel. So in these cases, we have basically two issues. We have a dysmotility and we have a very short segment of bowel. So what Bianchi understood in 1980, so Bianchi basically took advantage of two principles. So one physiology principle and one anatomical principle. So the physiology principle is that the contractile function of the bowel is dependent from the bowel size. So the more the bowel is dilated, the less the contractility, the less contractility has. And the second procedure, the second concept, it's an anatomical concept. So the mesentery of the bowel basically is made of two leaves, each leaf has some vascular termination that supply a half of the bowel. And this means that can be split. So the first procedure described by Bianchi, the longitudinal intestinal lengthening and tapering, basically is made of a longitudinal transection of the bowel and reanastomose. The segment, they should be around 20 centimeters, and by performing this procedure, so from 30 to 100% of the patient were able to be weaned off parenteral nutrition. However, so we know that most of these patients already had multiple abdominal operations, so they may have retracted mesentery and adhesions, so splitting of the mesentery becomes actually a surgical challenge. So what has been described is the Iowa procedure. So in this case, basically the antimesenteric portion of the bowel is attached to an organ host, that is either the abdominal wall on the liver, until it develops vascular collaterals, new vessel, and in a second step, after 6 to 8 weeks, basically we perform a sort of Bianchi procedure. So we transect longitudinally the bowel and we reanastomose. However, the risk of revascularization is very high and complication is very high, and for this reason, this procedure has been pretty much abandoned. And now I'm moving to the mostly common utilized procedure, that is the step procedure, the serial transverse enteroplasty. So this procedure can be done pretty much in any segment of bowel, including the duodenum, and is composed of a serial of transverse enteroplasty performed with a mechanical stapler. And so to give you a comparison between the two most common utilized procedures, so the Bianchi procedure and the step procedure, well, the reason why the step procedure now is the leading procedure for short bowel syndrome is because we don't have to dissect the mesentery. So the risk of vascular complication is way lower. It can be applied in every segment of bowel, even if the bowel is asymmetric. So if you have area of dilated or restricted bowel, and it can be applied in the duodenum too, and if the bowel is extremely short, it can be repeated in a second stage. And in terms of surgical complication rate, definitely the step procedure has less surgical complication, especially since we are not doing any anastomosis compared to the 3 anastomosis that we do in the Bianchi procedure. So the incidence of interbowel loops fistula, enterocutaneous fistula, necrosis is definitely less. And in terms of outcome, so the number of patients that eventually require a bowel transplantation is less with the step procedure, and the reason why is because it can be repeated. So we have a very short segment of bowel, we can do a step, and after a certain period of time, if that bowel is dilated, we can repeat the procedure. Well, I'm running out of time, so I just want to mention this. This is basically a procedure that has been recently described, but has been applied only in animal model just to prove the concept. So in this case, basically, we take advantage of the benefits of the Bianchi and the step procedure. Why? Because we don't resect the mesentery like we do in the step procedure, but at the same time we don't do transversal enteroplasty of the bowel, and this means that we don't transect the muscle fiber of the bowel, so we preserve the contractility of the bowel, like in the Bianchi procedure. However, it's very complex and there is not much experience out there. And then I want to just mention this medication that has been approved by the FDA in 2012, and the GLP-2 analog basically plays a main role in synergy with surgery, because what it can do, basically can foster a sort of adaptation. It can keep the adaptation of the bowel going, while surgically we try to increase the length of the bowel. Okay, so now, So in summary, this procedure should be performed in patients that fail to progress to alimentary independence. They should be performed when the maximal adaptation of the bowel has been reached. And in terms of which procedure, well, it depends. If we don't have bowel dilation and we have watery diarrhea as the main complaint, we're gonna perform the antiperistaltic segment of the interposition. In case of dilation, we're gonna perform the Bianchi or the step procedure. So in conclusion, the improved understanding of the pathophysiology and surgical anatomy of visceral organ failure is essential for the proper management of this complex patient. There is no single gut rehabilitation procedure that can guarantee a cure for all cases of short bowel. However, another important topic is that even if this procedure is not able to wean off completely the patient of TPN, at the same time, simply by reducing the amount of TPN and preventing the potential complication can help the patient to move towards visceral transplantation if it's indicated. So it can play a synergic role with transplantation itself. Thank you.
Thank you very much. And our next speaker is Enrico Benedetti, Professor of Surgery, Warren H. Cole, Chair of Surgery, University of Illinois at Chicago. And I'm going to guess he's got a set of colorful slides as dessert for lunch. Now I know why we scheduled you two after lunch.
Good afternoon, and thank you for coming to this exceptional, interesting conference. We love the fact that mostly are family and patients that are affected by the disease that come, and I compliment Oley in this long-term commitment to the health of this community. I start saying that the bowel transplant is a failure of the team to do it without. This is the last thing we want to do because it's a dangerous, a complex operation. But I believe that the fear of the procedure has led away even people that could benefit from it. So I like to start with this. So if you look at this history of the bowel transplant, you can see something interesting. Before 1995, there was no bowel transplant. The reason is because before there were no effective anti-immunosuppressive medication. In this year, tacrolimus was introduced, and in the pre-tacrolimus era, all the transplant of the bowel failed. But since 1995, the success rate went up, and in the 2000, actually, there was an interesting increase. Now, keep in mind that this is a rarely performed procedure. In a country of 330 million, last year only 67 adults and 62 children were transplanted. The majority of the patients are treated successfully by medical therapy and occasionally with some surgical procedure. And I can tell you that I've been in this field for 30 years. I'm amazed of the progress that our colleagues in medicine have achieved, and how much better we treat patients now compared even 10 years ago. It's mostly an American phenomenon. There is bowel transplant outside the US are a small amount. North America, the US, is the place where this procedure has been developed. And there's been a combination of bowel transplant alone, multivisceral organ done mostly for cancer, and liver bowel. The reason why many patients do not come to transplant is unfortunately the fact that the bowel transplant has not been very successful. But I want to make a few comments to this. So this is the curve of survival. This is years after transplantation. You can see that a lot of patients lose their graft and sometimes their life in the first 2 years. And then you stabilize in about 50% that have actually very long-term success. I want you to reflect on the fact that only the worst patient, the patient with more complications, that suffer multiple infections, that have liver failure, come to transplant. And if you remember the curve that Dr. Buchman showed with us, even in the best circumstances, about 20% of patients died over 5 years on long-term TPN. So as bad as it looks, consider who goes to transplant. And typically, the indication is life-threatening complication of TPN. We transplant only patients that are at risk of losing their life while on TPN. You wonder what would happen if you try to do patients that are less sick. And I'll give you some insight into it. One thing that I learned in the last 20 years is that you can consider many things, splenectomy, liver-free graft. What it comes down to, if you have a good team that can do a good operation, is this one. Lack of social support is the most important determinant of failure in patients that have initially technical success. So bowel transplant is not for everybody. It's specific for patients that have a good indication and then can take care of themselves. It's a very challenging situation, and only patients that are well-equipped with proper family support will actually do well in the long term. That's a lesson that we learn and will never forget. And this is a spectacular slide that shows it. They divided in group of patients that were successful after the first 2 years. And as you can see, the people with the lack of social support go down, while the people that have a strong social support continue to do well. That's one of the important characteristics you need to consider. I don't want to ruin anybody's digestion, but briefly, those are the 3 kinds of transplant done from cadaver donor. The isolated bowel that is becoming the most commonly performed. I would say that in a good center, most of the complications of long-term liver failure should be avoided by careful management of TPN and proper use of all the tricks that you heard from our specialists. This is the liver bowel. It's actually a simple operation, just one anastomosis on the artery and the vein up here. The pancreas is left behind for technical reason to avoid to do the biliary anastomosis. And this is the multivisceral that includes also the stomach, that is done mostly in children for cancer of the abdomen. But I want to tell you something about what we did at the University of Illinois. Our center has been very much involved in living donor bowel transplant. So, first of all, let me point out this particular fact. It's a rarely performed procedure. Only 109 bowel transplants in the US in 2007, which means the rest of the world maybe have done 15, 20 max. That's the entire waiting list for bowel transplant, only 250 patients. And this is an important implication. This is a curve that shows the effect of the experience of the center. So if you go to a center that has done less than 10, they don't do well. And of course, since the cases are far and few surgeons, few centers get enough experience. For example, if you look at these slides, 73 centers participating to the worldwide intestinal registry. This is Pittsburgh, that has done over 500. These two are Miami and Omaha, Nebraska. We are here with about 50 transplants. We are like number 5 or number 6 in the world, which means very few centers have acquired enough experience to do this procedure, which of course is an obstacle for its widespread application. Now, living donor bowel transplant, there have been a total of 62 in the world. So this is a procedure nobody has learned, except people that have dedicated long time to do it. And there is some potential advantage. For example, you have elimination of waiting time. I show you how we use it. We have a perfect match. You do the operation under optimal circumstances. The main problem is, do we put the donor at risk? And I will give you an answer in the next few slides. Dr. Grusner, my friend, standardized the technique. I was present when the first operation was done. And that's how we do it. You heard today that although the jejunum has the best absorbing capacity, the ileum is the only one that is capable to do it all. Can absorb vitamin B12, bile salt, water, protein, lipid. And with about 6 to 8 months adaptation time, you learn to do everything. So we take about 200 centimeters in adult, 150 in children, preserving some terminal ileum for the donor. And then we place it in patients that we call ultra-short bowel syndrome. As you can see, they have, in this case, only duodenum and sigmoid colon. Therefore, rehabilitation is impossible because simply there is no small bowel. So it's pretty straightforward indication. And we prove that it's a very safe operation for the donor. We have follow-up now many, many years. Interestingly enough, it's the only donation we do, of course, liver, kidney, even pancreas, in which the donor has benefit. Because if you remove the ileum, all the donors have a very favorable donor profile. Their cholesterol goes way down. I will not show the video, I don't have the time, but that's something that we did recently. But I want to share with you that between 1998, when I did the first one, to December 2017, we did 30 cases out of 54 in the US and 67 worldwide. So we have the largest experience in this particular field. That's how we monitor. This is Dr. Carroll video endoscopy. You can see that the bowel progressively has adaptation with the villi becoming taller and wider. And of course, we do that to rule out rejection. That is the reason why bowel transplant doesn't do as well as other organ. That's how the bowel looks like on biopsy. Start with the result in adult. We had a pretty decent result, 83 1 year, 70% at 3. And just to compare to a cadaver series, those are the 3 era. This is the most recent era in the International Bowel Registry. We are comparing well. There is a case that I want to make to you. What if you have an identical twin? So this is a pair of twin. This is the patient. He lost his entire bowel to vasculitis. He stayed on TPN only for 1 month. He came from Rochester to Chicago, and we transplanted using the 200 centimeter of small bowel from the identical twin. So we did not follow standard medical practice. The standard medical practice would be to keep him forever on TPN until he developed complication. We did it because, of course, you have no problem with rejection if you have an identical twin. It's like having your own bowel back. So with 200 centimeters, we had to put him on a diet, and he's now 15 years later, he's still doing very well. This is a case that I want to show you because clearly this is a great way to solve the problem. If everybody had the identical twin, there wouldn't be a problem. But give us some hope that as we improve the immunosuppression and we do the operation better and better, maybe we can offer this operation to patients that are not as sick as we have done so far, right? This is the publication. This is another case. We did 2. This one we did it about a year and a half ago. A trauma victim on the south side of Chicago, mistaken identity, and his identical twin donate. Off immunosuppression, back to normal life. Worldwide have been 5 living donors between identical twin, 1 in Stanford, 1 in Oxford, 1 in Geneva, and 2 at University of Illinois. All 5 did great. So the problem is the immunosuppression, the rejection. The 200 centimeters are fine. We have done the bowel transplant in patients with preformed antibodies that don't dwell in cadaver because we have time to clean their blood. So that's another indication for bowel. That's a paper we publish. We adapt this actually in situation where we auto-transplant the bowel since we learned the technique. This one, for example, is a case of a giant desmoid tumor. And rapidly, now we remove a piece of bowel before removing the tumor. Then we remove the tumor along with the cava. We put back the piece of bowel, and the patient is no longer on TPN. That's a lesson that we learned during the transplant. But let me switch to children, which is, to me, the most exciting part of our work. In children, the mortality was very high, especially around 2002, 2004, in patients that develop liver failure. In fact, that's what accounts mostly for the mortality on the waiting list for this patient, the combined liver and intestinal failure. We know that in children less than 6 years of age, living donor do better than cadaver. This is even more true in children less than 1 year of age, in which there is a clear advantage to use piece of liver from the mother. So we decided to combine the two, and I'll show you some of the case. So we did some of the cases bowel alone, some of the cases combined liver bowel from living donor. And we did 6 and 6, and we have now a follow-up exceeding 10 years. We learned that you cannot do in too small a baby. We need to have at least 8-kilogram baby, but the 4 that we did isolated with living donor bowel, minimum weight 8 kilograms, they all survived, they're all alive and well to this day. Show you some. We learned not to try to do the very small baby. They just do not tolerate the procedure. But if we use this minimum, we did quite well. For the combined living donor liver bowel, we did 6, mostly from the mother. And those are mothers that, in 3 cases, went back to the OR twice. Because we did it in 2 ways. The donor, by the way, did great even when they donate liver and bowel. That's a paper in pediatric transplantation. We did it in 2 different ways. In stable patients, we did liver and bowel in the same setting. And in other 3 cases that were sicker, we did the liver first to stabilize the patient and then the bowel to follow. This child was transferred to us almost in extremis, so we stabilized his condition using the part of the left lobe of the liver of the mother, and then a week later we went back and we put the bowel in, and we cover with skin. And this is the overall result of our series. Living donor liver bowel, this is the cadaver experience. As you can see, not much progress done. This is our curve. We did actually a recent paper published last year in which we follow up the 10 children that we did that were at least 8 kilograms at the time of the transplant. And please note that at 10 years, we had 7 out of 10 alive and well, which doesn't happen very frequently. And they show actually a catch-up growth. They reach the same size of their peer, which again doesn't happen very frequently. So the living donor bowel, it's good for a few things. If you're lucky enough to have an identical twin, no-brainer. If you have a HL identical sibling, 25% your sibling will match all your 6 antigen, very good, they do very well. If you have preformed antibodies, we may manipulate and make your transplant safer. Otherwise, we simply do a cadaver bowel transplant that does very well. In children, unfortunately, nobody has taken the lead. Although in Brazil, they call me with this technique, 1 case has been done in São Paulo. They did the 10 cases in Japan. They all learned from our series, so we are proud of that. They will show them how to do it. And a surgeon at the King's College in London did the liver bowel. So some people are trying to do. But to me, this is the most spectacular series because I'll go back here. This is a 10 years follow-up, which means here I have a cumulative series of meaning 70 years of follow-up, right? And in these 70 years of follow-up, we did not witness a single rejection. Consider that the rejection in cadaver bowel is approximately 45 to 50%. For children, this is a formidable strategy. Now, this is not a simple journey. I told you that the most important thing, you need to have family and patient that can cope with you. But I can tell you that if you try, sometimes things goes well. That's the same child before and after. You can see the color. This is a mother that was born in El Paso. Sorry, the child was born in El Paso from a Mexican mother, and believe it or not, Public Aid Texas paid for the liver bowel transplant. 12 years ago, the child's still alive. Sometimes people grow, and if you wait enough, somebody even graduates from high school. Thank you very much.
We have an emergency bracelet that all it says is low blood pressure, fainting risk, implanted IV line, call, my eyes aren't that good, Joe or Daniel. Does anyone here? Does it belong to anyone? Okay, we'll keep looking. Thanks.
Okay, we're going to take some questions for Dr. Benedetti and Dr. Spaggiari.
Hi. Are either of you familiar with a procedure for reducing dilation in a child where they're basically cutting or stapling through the intestine and then cutting off the excess? Kind of like a stomach stapling, but to make it smaller. And what are your thoughts on that?
Well, that would be a tapering procedure, and is done mostly in case of blind loop syndrome. Of course, this is addressing simply the motility. As Dr. Spaggiari explained, a dilated bowel doesn't move very well. So in some patients, it's indicated mostly not to address so much the intestinal failure, but as a cure for the blind loop syndrome that causes bacterial overgrowth and all sorts of complications. So in the right patient can be quite helpful.
Okay, thank you.
Enrico, what's your thought in terms of quality of life as an indication for a bowel transplant? So say you have somebody who they've done okay on parenteral nutrition, but they're really not happy with it, or they're depressed, or perhaps maybe they're even potentially suicidal with staying on parenteral nutrition for the rest of their life. So what are your thoughts? But their liver's fine, they haven't had many infections, they've done well otherwise.
Well, I think in 2019, the doctor must be advocating for his patient without patronizing. So my personal preference, and I apply in a case that with Dr. Carroll we transplanted 9 months ago, I prefer that the patient is informed and make the final choice. For example, we had a patient that had a subtotal enterectomy, was left with about 15-20 centimeters of bowel, and we stabilize him, reconstruct the bowel, and at which point he asked me, can I do a transplant? And I replied, the standard of care in the US is that I do transplant only for life-threatening complication of parenteral nutrition. He said, yes, but what if I want to do it anyway? Because I want to go back to work, I want to go back to my normal life. I say, well, if you want it, this is the risk, this is the survival rate, and please go home, talk with your family, and come back and tell me what you want to do. He came back and said, I like to be transplanted. And we did it, and he's back to work, and he's doing great. So in a way, I believe that the patient voice must be listened to without promising the moon, without promising success all the time. But people have the right to choose.
Mario, if you have a patient who has one or maybe several dilated loops of bowel, 6 centimeters or so, but they're large, they don't have problems with bloating, their diarrhea is the same as would be expected. Would you offer those patients an operation, or do you feel that you need to demonstrate that there's bacterial overgrowth and that the intestines kind of become a cesspool? What are the what are the conditions other than anatomic that you would look for, if any?
Well, again, as I mentioned before, so these procedures are performed in very few cases, and there is no such a standard indication, simply because these are patients that already had many surgeries, so the anatomy is different, and every case is different. So a dilated bowel, it's a bowel that potentially has a dysmotility, so bacterial overgrowth, translocation, and so forth. However, if none of these symptoms are in place, I don't see any indication for surgery. If they are, or the moment they develop, of course, yes. But if there are no signs of short bowel syndrome, of course, I mean, it would be, in my opinion, a futile procedure.
Well, think of some questions and come up to the microphone, folks. There's a lot of questions to be asked here. Enrico, what about age? Is there an age limit in terms of transplanting bowel? And if not, what sort of comorbid conditions might be things that would concern you?
Well, certainly, as far as lower limit of age, I don't see a lower limit of age. I see a lower limit of weight, at least for living donor bowel. Although for cadaver, my colleagues, especially in Pittsburgh, have done children even 4 or 5 kilograms of weight. I think the trend is to weight when they're a little bit bigger. So it's not so much the age, it's the weight. Okay. And of course, children with short bowel syndrome actually have trouble to reach that weight. And it's difficult because they lose the ability to eat. They don't like to eat. They have what's called food aversion. In fact, in many ways, it's important to do it sooner than later. As upper limit of age, we have done as old as 55. I think the bowel transplant is a long journey. It's not for compromise, it might be a little older patient. I don't think it's in their best interest to be transplanted. I would say that somebody mid-age or early age, those are the best candidates. And you can have some spectacular result, no doubt.
We got a question here?
Yeah. I have intestinal failure, and I've been putting off transplant for about a decade now. I'm wondering how fast this is developing, like in another decade, 2 decades, is this going to be a more viable procedure? Is it still going to be 50% chance at 5 years? That's really what I'm wondering. Well,
I think your decision is very individual and has to do, number one, of course, the absence of no life-threatening complication, which I'm sure it's your case. You're tolerating the parenteral nutrition well.
My liver almost failed 3 years ago. I switched to Omegavan. That's helping now.
Yeah.
But it's been lots of life-threatening complications along the way. It just seems that I have a better chance dealing with that than transplant at the moment, because I have full intestinal failure.
Yeah, and I cannot tell you that the progress has been so exceptional that I can guarantee you a high rate of success.
Well, right now, I don't eat, but I'm willing to wait a decade, 2 decades, however long. I've survived 15 years so far, so.
Yeah, I have the clear impression, at least in our practice, that number one, we reach a point of learning curve that has maximized. And that includes not only the operation. We do the operation well, but also I think we know how to choose the right candidate. So for the last couple of years, we had a lot of success, which we didn't in the past.
But do you think like the odds of surviving longer are going to continue to increase as time goes by, as more knowledge, more research?
Definitely. We learn a lot of lessons. And the immunosuppression we perfected. Many of the patients we have done in the last 2 years, we didn't have any rejection, which in the past was almost the rule. I would say that we are progressing, and maybe one day you look at the field and you say, maybe I'm ready. But you are the one that make the decision. And there's a lot of people that are working on it, and the field is progressing, the immunosuppression is more refined, we learn the trick, and we learn who should we do and who should we avoid. Somebody that is intelligent, that can take care of himself, that has a strong family support, that's what you want. Then you want a surgeon that has some experience, some judgment.
Mm-hmm. Good idea. Okay, thank you.
Next.
Hi, two quick questions. From what I understand, that like sort of nationally recognized bowel transplant institutes and hospitals, the survival rate, the 5-year survival rate is more between 80 and 90%. At least that's what at least one person out of one of these places have told me, as opposed to 50%. Is that the national registrar, as opposed to, say, Cleveland Clinic or Georgetown or Miami?
The curve that I showed, the 50% curve, is a cumulative survival and include bowel transplant alone, liver bowel, cluster transplants, and include also center with little experience, center that maybe in Brazil do one case every decade and so forth. So if you then look at statistics of center of excellence, such as Pittsburgh, Omaha, Nebraska, Georgetown, our own, we have a 75% 5 years in adult, and you've seen in children well over 70 at 10 years. So clearly, the results are better in centers that have more experience, US center mostly. Yeah. So the 50% is what the public see, and people don't consider the two factors, right? That is a combination of case, cluster plus liver bowel plus bowel alone, and there is a mix of center, right? Some centers are very aggressive and have poor result. Some centers are prudent, have good surgeon, and have good result.
Yeah. Second question is, what have you seen regarding like the causes of the bowel transplant affecting its success? Like, say, motility disorder with some sort of like tissue problems, as opposed to, say, short bowel syndrome or other causes. Is the causation for the necessity for the procedure affect its result?
I would say that if you study the patient well, motility disorder can be addressed, and technically it's easier to do bowel transplant for motility disorder because the abdomen is large. Of course, the standard short gut syndrome post-surgical, those are patients that are ideal candidates, and there is no question about the anatomy or what is going to work. But the weak point of bowel transplant has always been the risk of rejection, because when the bowel rejects, you lose the barrier, patient translocates, so most of the deaths are a combination of rejection and sepsis. So the moment that you are treating the rejection, that the barrier of the bowel is broken down, you're giving extra immunosuppression, which is a fatal cocktail, right? So everything is aimed to minimize or avoid rejection. And I think now we are learning how to do it with sort of a complex group of drugs that we use to have always enough immunosuppression aboard. That's what we learn. We learn how to prevent.
And patients with Crohn's disease, for example, that have been transplanted, the incidence of recurrence of Crohn's is very low because obviously of the immunosuppression. But actually, we have another question.
Yeah, this actually jumps in back on the causation question. I was wondering your thoughts on transplant in the context of underlying disease that is generally progressive, whether it be or recurrent, whether it be autoimmune or like progressive autonomic disease. In that context, where the thought is that, what caused the problem could potentially recur with a new organ.
Yeah, as I stated, the functional disorder of the bowel are more difficult to study and to understand. Right. And the key is to understand which part of the bowel work, what doesn't. Because we can do everything and nothing, right? We can add stomach, we can add colon, we can do a lot of stuff. But for me, in motility disorder, the first order of business is to understand what works and what doesn't. If you are accurate in detecting the segment of bowel that cannot help, then you can be quite precise in addressing the problem. As you know, very often these patients are complex. They may have mastocyte disorder. They may have other problems. But fixing the GI motility with the bowel transplant changed their life. They still remain challenging, but if you choose well your case and you know how to detect the functioning part of the bowel, you can succeed because it's easier to do technically.
Thank you.
Okay, thanks very much. Our next speaker, we're going to welcome Ann back here. Ann's doing a double duo because I think she's the only one on the program that was forced to give 2 talks, kicking and screaming. So this afternoon, she's going to talk, we talked a little bit this morning about oral rehydration solutions. Ann's going to speak about treating dehydration and with rehydration. Maybe we should have waited even a little bit longer, but I can feel it already. Okay. Yeah.
All right, well, we did kind of cover this a bit this morning, and I'm going to try and expand a little bit and then maybe answer some of your questions in a little more detail if you have any regarding rehydration. So again, I have no disclosures. So just a brief overview. We're going to talk quickly about how you end up getting dehydrated, how you recognize it when you're home, and so you know what's happening, and what you can do to prevent it or try to manage it, and if it's in its early stages, and when to call your provider so that we can intervene and help you out before things get too serious. So the causes of dehydration are pretty clear, and you guys are probably all really familiar with most of these. First of all is inability to take fluid by mouth. This is probably the biggest problem more in patients that have motility disorders because they drink fluid, it doesn't empty out of their stomach, so they don't get any benefit from it, and so they can't stay hydrated. Fluid losses come from diarrhea, which is mainly a huge problem in those with the short bowel syndrome. They can take the fluid in by mouth, but absorption of the fluid is a problem, and so you have increasing output as you take more in. So you end up in a net negative balance, so you're putting more out than you're getting in. And you can also lose fluid loss from vomiting. Also, if you have drains or tubes that are decompressing part of your bowel, you're losing fluid from that, so we need to keep an eye on how much you're putting out. If there's a change in that, you can get dehydrated. You need to be aware of things that you may not necessarily be sensitive to, and that's increased sweating. So in the really hot weather, if you're outside, you may have fluid losses that you're not really measuring. It's not anything you can measure, but can increase your fluid requirements so you can get dehydrated. And then if you have any other cause to lose fluid through the urine, and the one that may most commonly be seen sometimes in patients that have TPN with high sugar content is that if you're getting hyperglycemic, you may actually have urine concentrations of glucose that go up, and so that pulls more fluid out through the urine. So all of these things can combine together in various combinations to increase your risk of dehydration. So how do you recognize it? Well, first of all, and most of you are probably doing this already, is just be alert to what's happening. If you recognize suddenly you're having more stool output, increased vomiting, you may have a gastrointestinal infection, so you can get one just like anybody who doesn't have short bowel, and so that can increase your losses, but you may not be able to catch up like someone with a normal bowel can. Or be alert if you're outside, if it's hot weather, just be aware that you may need more fluids. So symptoms can start out with just feeling a little bit lightheaded, and you may notice this predominantly when you're getting up from sitting down or when you sit up from lying down. If you suddenly are feeling like you're a little bit lightheaded or like you might pass out, that can be a sign that you don't have enough blood volume so that you're getting dehydrated. You can feel tired, you may feel like you need to sleep more, or you may just simply feel exhausted, like you have no energy. One of the signs to watch for is if you're more thirsty. Now, patients with short bowel are often thirsty all the time, so this is a little bit of a difficult problem to recognize if you're more thirsty. But if you have a motility disorder and you're suddenly feeling like you need to drink more fluid, you're feeling dehydrated, there's a thirst, that means a sign that you may need more fluid. Things to watch for in terms of your urine output is if you're not urinating during the day, then you're probably not, you don't have enough fluids. Your body, your kidneys are trying to hold on to as much fluid as they can, so you're not making urine. During your TPN infusion, you should be making urine. So if you're not, that means you're getting so dehydrated during the day that you're just barely catching up during your infusion. So that's a sign. Your urine may get darker in color because your kidneys are trying to hold on to fluid, so everything's getting more concentrated, so it may look more bright yellow or even tea-colored if it gets really concentrated. You may have headaches. Muscle weakness or muscle cramping can be a sign that you're a little bit dehydrated. Your heart rate may go up, so you may feel like you're having more palpitations, and again, that may happen more if you stand up from sitting, or if you sit up when you're lying down, you may be more aware of your heart racing. And then if it goes on and it gets more severe, you may find that you're confused, you're delirious. So this is where caregivers can come in and sort of say, wow, they're not really acting like themselves, something's not right here. And it can progress, and if you wait too long, you can go into a coma, and severe dehydration can be fatal. So you want to recognize it when it's in those earlier stages so that it can be addressed. So I'm going to do a little mini lecture on how we absorb fluid. So this is a picture, a microscopic picture of the intestinal lining. And so people have been talking about villi, and people have been talking about the cells. So the villi are those little projections. This is a microscopic picture of the lining of your gut. So those little finger-like things we call villi, and all of those things along the sides of those are the cells that are absorbing the fluid. And this is like a little cartoon of that. So the villi are those long finger-like projections, and along the side of those villi are the cells, which are blown up in that little circle onto the right. So all those cells are lined up along those villi. And each one of those cells is working to try and absorb fluid, as well as other things, but we're talking about fluid right now. So this is a picture of that cell. And so what I want you to understand is that there's two ways that fluid gets absorbed through the cells. There's an active transporter, and then there's passive. So that little red circle there on the lining is actually an active transporter for fluid that will pump fluid from the inside of your bowel into your bloodstream ultimately, but to the other side of the cell. That is dependent upon glucose and sodium, so sugar and salt. And that's why we focus so much on what oral rehydration solutions are, because that transporter needs to have glucose and sodium in very specific concentrations of each to optimize its pumping function and pull fluid in. So when you have an oral rehydration solution, we're looking at a specific glucose concentration and a specific sodium concentration, which together, and that's the key, are going to pull the fluid in. So optimize how much each one of those cells is working to keep you hydrated. Now, on the passive side, sodium is going to move either from the inside of your gut into the blood or vice versa, depending upon which side is more concentrated. So if you're drinking solutions that are really concentrated, like, say, juice or soda that has a lot of sugar in it, that's a concentrated solution. So fluid is going to move to the side where it's more concentrated and try to dilute it. So if it's more concentrated inside your gut, fluid is going to move into your gut, and that's going to give you more diarrhea. So that's why it's important that you not drink super concentrated drinks as well, okay? Sodium and water can move in either direction from the inside of your bowel into the blood or vice versa, depending upon the relative concentrations on each side. And the side in the blood is always pretty much the same. So we can control the concentration that's inside the gut by what you're drinking. So if you drink those solutions that are higher in glucose or sugar, then that can increase your diarrhea. So the principles of oral rehydration are based on that mechanism for each cell to absorb fluid. So fundamentally, we want to avoid very concentrated liquids, okay? We also want to avoid very dilute liquids, and this is why we say don't just drink water. Because if you just drink water, now the inside of your gut is now less concentrated than your blood. So the sodium is going to move from the blood into the gut, and where sodium goes, fluid goes. So now you're drinking water, but you're actually increasing how much you put out. So you may drink a cup of water, but you may put out 2 cups of water. So you're not going to be able to hydrate yourself if you just drink water, because you're pulling electrolytes from your blood into the gut, and then water's following, so you're actually increasing how much you're losing. So understanding what those concentrations are in terms of what you should be drinking is really critical. And the other principle is to sip incredibly slowly. So you don't want to gulp things, you just want to let it trickle in little by little. You drink too much at once, it's going to rush through much faster than if you just kind of deliver it in a very slow, steady fashion. And use liquids with that balanced sodium and sugar content, which are what we talk about when we talk about oral rehydration solutions. So what is an oral rehydration solution? Okay, so this is what the World Health Organization recommends for trying to optimize that absorption into your gut. So per quart or liter, you want to have 20 to 25 grams of glucose. So you can look at the label of something you're drinking and you can say, okay, if in 8 ounces I have 5 grams, well, multiply that by 4 because you got a quart. If it's 5 grams, then the total is going to be 20 in that quart, so that's what you want. If the concentration in an 8-ounce serving is 45 grams of sugar, you're in trouble, okay? Because now you got to multiply that times 4 to get a quart. So it's got to be diluted. You can still drink those things, but you just have to dilute them, and that's what that book that Dr. Tappenden was showing you this morning provides in there, some recipes on how to dilute. But you can calculate it if you recognize this, and you can calculate how much is in a quart. Now, the other thing that's important is that you have enough sodium, which the amount that you want is 1.6 grams of sodium, which is about 3/4 of a teaspoon of salt per liter. Okay, and again, divide that by 4 if the serving size is 8 ounces. Okay. There are commercial solutions that are available. Most of these also have potassium, which is not a bad idea necessarily when you're in a short bowel syndrome situation, unless you have kidney disease. So if there's an issue with your kidneys, you want to be careful about using solutions that have potassium. Your kidneys may not be able to handle the potassium. Otherwise, it's probably just fine because you're losing potassium along with the fluids that you lose. And then there's the homemade solutions that we talked about that are in that booklet. And you can come up and talk to me anytime over the next 2 days. I can give you some pointers. So this is the WHO recipe, which is basically take a liter of water, which is a quart, roughly, add a 1/2 teaspoon of table salt, add 2 tablespoons of sugar, and then flavor it. So you can flavor it with anything that's a sugar-free flavoring. There are those little Mio drops. There's the Crystal Light packets. And you don't have to put a lot of flavor in it. What you're trying to do is just make it a little more palatable. And then Reed Nishikawa, who is a long-term friend of Oley, also mentioned to me this morning that using a straw and putting the straw kind of far back in your mouth, you don't get the taste of the salt. And so you may be able to sip it more slowly. And if you use a small straw, it kind of limits how fast you can take it into, which may also be helpful. So that's another little trick. You can add a little bit of baking soda, so that compensates for the bicarbonate that you may be losing if you're having more diarrhea. And salt substitute is a way to get potassium into your hydration solution if you have an issue with potassium absorption as well. So importantly, when do you call? Okay. So the oral rehydration solutions may not necessarily improve your symptoms quickly. And so if they don't, then you can try that for a short period of time. But if you're not feeling like you're getting any better, call us. If you don't make any urine for 8 hours, we want to know it, okay? Because we know you're getting too dry. And we can step in and provide some additional hydration that you may not have available at home. Lightheadedness is one of those early signs. So if you start doing your oral rehydration solutions when you're lightheaded, if that goes away, then you're good. You're treating yourself, and that's great. If you find your blood pressure is lower than usual, some of you may monitor your blood pressure on a regular basis. So if you start having these symptoms, check your blood pressure. If it's running really low, then you know you're dehydrated. Start increasing your oral rehydration solution intake. But if that doesn't resolve your symptoms, make sure you call. Some of you may have, and I know that I provide this for some of my patients, extra bags of saline that they can use just for hydration purposes. So in addition to your TPN bag, if you are getting dehydrated, you feel like you're dry, you can infuse an extra bag of just saline to kind of tank up a little bit if you feel like you're getting dry. So if your blood pressure's low, your heart rate's faster, you can do that. If you don't have those at home, you're not provided with those. If you call, we may be able to set you up, or your provider may be able to arrange for some additional hydration. Cold and clammy skin means you're kind of getting a little bit beyond the point where you should have called, so make sure you're calling as soon as you can. I have a little picture of this pinch test. So this is a way to check your skin to see if you're getting dehydrated. So when you pinch your skin, it should bounce right back. It shouldn't stay in that little tent like it is there on the right. So when you're getting dry, if your skin is staying up like that, it needs more fluid to bounce back. So that's another way that you can tell that you're getting dehydrated. So with that, I'm going to stop because I'm sure there's going to be some questions, and we'll take those in a little bit of time.
And our next speaker, I'm told, just arrived, Tim Sentongo. And Tim is here to talk to us about special issues in home parenteral and enteral nutrition for special patients, not seniors, but our kids. Do we have him? Oh, okay. Okay, we're going to swap. So right now, Tim looks a lot like Kelly Tappenden, who is here. Yeah, that's Tim. And she's going to cover the next talk on lift echo. Thanks, Kelly.
Okay, last year, Kishore Iyer and I were able to introduce to you, who were able to attend, the concept of echo. And although I don't have Kishore here to entertain all of you today, I am going to share some of the progress that we've made with that. Now, this is a new way of treating patients and extending knowledge across the country to practitioners that may not be familiar with certain areas. And we think this applies to intestinal failure. This is a map of the US, which shows intestinal transplant centers, CMS recognized intestinal transplant centers, and then intestinal rehab centers. So you can see that there are large portions of the country where patients will have a hard time getting to. And this is not completely representative of where things can be done. Of course, Dr. Benedetti just shared with us some of his expertise in living donor liver transplantation that's done at UIC. You can see here, though, that CMS does not yet recognize that center. But there's significant expertise, as you've been able to see in the meeting today. Now, ECHO. This is a concept that was developed by Dr. Sanjeev Arora at the University of New Mexico. He's a gastroenterologist that takes care of patients with hepatitis. Now, New Mexico has relatively few centers of excellence. He is the center of excellence. His clinic is that for New Mexico, and there are many rural areas where many individuals were needing his care. The expertise wasn't by them, and he had an extremely long waiting list. So he was really frustrated by that and wanted to try and identify a need for the patients that needed access to specialty care because of their complex health conditions. There weren't enough specialists to treat everyone who needs the care. And what he developed was ECHO to train the primary care clinicians to provide the specialty care, okay? Allowing the patients to stay in their own community, giving their primary care physicians expertise so that more people could get the care that they're needed. He always says patients get the right care in the right place at the right time. And that's really the concept for this. This improves outcomes and reduces costs. He published this data in the New England Journal of Medicine, looking at their initial results with ECHO. And you can see here the treatment outcomes for individuals who were treated at Dr. Aurora's clinic at the University of New Mexico Hospital versus in the ECHO format where he was extending this knowledge to the primary care physicians. Now, what you can see is that in the bottom two lines, the treatment outcomes were not significantly different. In fact, the ECHO, if you're looking numerically, was slightly higher benefit than at the University of New Mexico. What is significantly different, though, is the diversity of the patients that were seen. With it being much higher, he was able to extend his care to underserved groups by using the ECHO clinic. And so that's been something that there's been a lot of interest then trying to extend that model with. In this instance, they showed that it benefited rural physicians. They could get CME, continuing education credits for that. It allowed for less isolation, more professional interactions and learning, better retention. It's kind of a fun environment where there's work and learning at the same time, so you get both accomplished by having this specialty consultation. So like I said, it started off in GI. Now you can see that there is a breadth of ECHO clinics, specialties reaching many, many different areas, and this is not exhaustive either. This is something that's really taken on since they started it in about 2003. It's taken on so much that there is an act, the ECHO 2019 Act, that's being introduced by Senators Schatz, Kane, and Murkowski, actually supporting the ECHO model of healthcare provision and asking for there to be grants and extended technical assistance to help further that model even more. So where this is also leading to is support from the American Medical Association. They met at their annual meeting just a couple weeks ago and adopted a policy calling for increased application of telemedicine, and actually mentioned Project ECHO as one of the exemplary ways to do that for rural and remote care providers. Well, we think we can do better than rural and remote care. One of the principles of the ECHO model is that it's very, very common disease. And so in those rural areas, there will be lots of individuals needing that care. But we argued that given the rare disease nature of intestinal failure and the very few centers of excellence, that the ECHO model could certainly apply to something like intestinal failure too. And so as I told many of you last year with Kishore, and you may have seen in the Oley newsletter, we've been working on putting together an intestinal failure echo. You can see here, this is the design that we came up, and we call it LIFT Echo, Learn Intestinal Failure Tele-Echo. It has the central location at Mount Sinai Hospital in New York with Kishore, but because there are so many different disciplines and sites, there's actually experts coming from multiple locations that I'll show you in a minute. We are supported and are using the original ECHO model in addition to having an advisory board. Now, for those of you who want to go look, here is our website that will launch next week, okay? liftecho.org. It will just be going live next week because we have just started. So with that, I want to show you a little video that's been done to describe it.
I work in the field of intestinal failure. It's really a devastating condition, compounded by the fact that it is what's called an orphan disease. It's very rare. So the specialists available to treat this devastating condition and the complex therapies that it involves are really very few and far between. I get patients who sometimes drive up 8-9 hours. They have to drive all the way to see this transplant surgeon because they don't have somebody closer by who can provide them with the medical oversight that they need. We're talking about a devastating disease. Maybe there are 40,000 such patients around the country, and there are 30 or 40 programs around the country that have real expertise in this.
I'm a specialist in liver disease. I used to run a dedicated hepatitis C treatment clinic.
I came across the amazing work of Dr. Sanjeev Arora, who is a hepatologist at the University of New Mexico in Albuquerque. Dr. Arora launched a project called the Project ECHO about 10-15 years ago, and he encountered, I guess, a similar problem, but for a much more common disease. He was dealing with hepatitis C. Dr. Arora was very astute to realize fairly quickly that the problem here was a scarcity of expertise. That was the precious commodity that was in short supply. There are echo projects now for really, you name a disease, there are echo projects, HIV, hepatitis B, chronic pain, mental health. And I said to myself, why not intestinal failure? Thank you for coming and representing the patient voice. Here. This is the launch of our first LIFT ECHO project. LIFT stands for Learn Intestinal Failure. What telelearning does is it changes the equation. I don't have a direct relationship with the patient, but I have a relationship with the non-specialist clinicians. They might be doctors, they might be pharmacists, nutritionists, nurses, who are doing the best they can, really in the front lines of looking after these complex patients in their community, often with very little support.
As I said, that's for decompression only, as he is not in continuity.
What our ECHO project will do is to provide a virtual multidisciplinary expert group of clinicians to support non-specialist clinicians who are looking after these patients out in the community.
I'm wondering, maybe David could send that as part of the attachment when he sends out the Zoom meeting info?
Our goal with the LIFT ECHO project, we're starting with 2 clinics a month. We're actually using Zoom that is available to us, free license from the ECHO Institute in Albuquerque. Think of it as a virtual curbside consult that might happen in an academic institution. You're walking down the atrium, you've got a complex patient, you suddenly say, oh, there's Bob. Bob knows everything about this. Let me stop Bob and ask him what to do with Mr. Smith. And Bob tells me, and I go away feeling a little better and knowing a little more. I think we will change the face of how intestinal failure patients are managed in the US using this platform.
Okay, so that's the concept. Here is our advisory board, and many of these individuals are serving on LIFT at each of our clinics. You can see some of the individuals, I'm sure, who are on your team. They're coming from Nashville, Scottsdale, Brown, Mount Sinai, as you heard, Rhode Island, Brown, of course, University of Illinois at Chicago. And we have various partners, including the Oley Foundation. They were one of the original partners to work with us. So Dr. Iyer, Dr. Winkler, myself, Oley, and Aspen were the original group that have been working on this. And I am really happy to tell you that we did start with our clinics last month. We thought that might be a little ambitious, but we did start. We're having clinics on the first and third Tuesday of each month, and we discuss one case. So we have clinicians from various areas around the country. Anyone is welcome to participate. They send in a case that they may be struggling with. We, as experts in the echo, get together, we discuss that with them, and we really work through that case, making suggestions. And then we have a short didactic program that helps educate the clinicians on what it is that goes into caring for patients like this. So you can see many of the topics we've discussed today are included, but even things that are very basic, like prescribing PN. We know that there are individuals being cared in a non-center of excellence, and their provider would like help prescribing PN. So there's many different topics that we'll be covering with these remote clinicians. We have had approximately 100 participants in just 3 clinics without even having our website go live or a lot of advertising. You can see that our participants are from all over the country. So these middle areas where we don't have a lot of centers of excellence is certainly something that we're happy about. How you can get involved is by talking to your provider, your team, and having them sign up to participate here. We want you to help us get the word out, and so you can do that by giving them this liftecho.org website. It's not for patients to come to the clinic, though. It really is different than telemedicine, where an expert would be providing direct patient care. We're providing patient care through education of non-specialist clinicians. So that's one of the things that's different about it, and we would like, though, to increase the care that all of you are getting, and even more so, colleagues or individuals who may be in the situation as you, but they don't even know to come to Oley, right? They don't have a specialist providing their care, and they don't even know that there is a consumer advocacy group like that. Those are people we really want to try and access also. So with that, I will be happy to answer any questions once we're done this session.
Our next speaker is Dr. Tim Sentongo, who Joan Bishop had mentioned is Associate Professor of Pediatrics at the University of Chicago. Tim was driving, I think it probably took him longer to get here than most of the people to fly, because traffic's bad here today. So we do have a rehydration station. And Tim's going to speak to us about a pediatric topic, special issues in home parenteral and enteral nutrition for special patients, our kids. Tim?
Thank you very much, Alan, John, and for all the organization of Oley for giving me this opportunity to come and give this presentation. And yes, Alan said it all. There's always a miscalculation when you live in the city. Anyway, I'm glad to be here, and this is a great organization. I tell my patients it's here, and thank you very much to the organizers of it. My topic today is special issues in home parenteral nutrition, home and enteral nutrition for specialized patients, our kids. So I'm a pediatrician, and I'm aware that I really feel that Oley is so resourceful. There's a lot of information that comes through Oley that I felt that my presentations should be given more of the broad strokes, because there's a lot of detail that you're going to come access to. So I'm going to tell you how I think when I'm taking care of a patient with home parenteral and enteral nutrition, and the goals that I set to improve the outcome of that child. All right, so I start out by talking about the three-legged stools of human beings. So basically, human beings are unique, and we're unique in that we have a large body size, we have an extended period of childhood, and we have a large brain. Therefore, if you compare human beings to many of the other species out there, one of the reasons why we're able to dominate has been distilled down to these three major things. One, we grow to an ideal body size. Two, our brain, especially the frontal brain, grows significantly much more than many of the other species out there. And we're children for at least 18 years. So compare yourself to some of the other species out there, say like a mouse, or a rat, whereby has a gestation age of 3 weeks, is an adolescent for 6 weeks, and then by age 5 months, it's an adult, and the final weight is 500 grams. So you can really see that these species just have no chance to compete with a human being who is much bigger and spends more time learning, making mistakes, learning from them, and by the time you become an adult, you've mastered a lot of skills. You could also compare yourself, say, with a large animal like, say, an elephant, which has a gestation age of 21 months, which is very inefficient, is an adolescent for 17 years, about the same time as a human being, and by age 20, an elephant is an adult. Its weight is about 6,000 kilograms. Now, if you change that to pounds, that's about maybe 15,000 pounds, and has a lifespan of 30 to 40 years. But you can see, as a creature, it's very large, it's very inefficient, it cannot dominate. So we humans are very uniquely placed in that we are gestational age of 9 months, adolescents, we are an adolescent for 4 years, from age 12 to 16, and by age 18 you're an adult, and you have a body size, and you live for about 80 years. So all these are unique things that must be met for you to become, for you to be able to dominate. So it comes down to what I call the three-legged stool of pediatrics. Essentially, there are three things that have to be met to become a successful adult. Again, I am a pediatrician, and children are cute, but whenever I look at a child, I have to figure out one day they're going to be an adult. So what should I do right now, which is going to be a stepping stone to make them successful? Because at some point, they'll be 18, and then all of a sudden, society expects them to know everything, make the right decisions, and be successful. But you have to get there through small steps, which have to be very intentional. And that's what I call the three-legged stool of pediatrics. So first of all, it is the brain. You have to create an environment that enables the brain to get to the right size, have the right nutrients, so they can learn the problem-solving skills necessary. Then two, at some point you have to dedicate them to learning. Therefore, they must be teachable. And finally, all that hinges on nutrition. So all these three things are somewhat independent, but very interdependent on one another. And as a pediatrician, I want to make sure that those are in place, because if those are in place, whatever the disability somebody has, at least they'll be able to compete out there. So what I'm going to talk about, obviously, I'm going to try to define what normal growth is, because that comes down to what I'm going to sum up with. I'll obviously highlight the impact of intestinal failure on growth. And I won't talk as much about the history, because I really feel that this audience here is very well versed with the history of all these nutrition support approaches we use. And then I'll just touch some of the nutritional goals and challenges and interventions that we have to implement, especially in children. So malnutrition is one of the big things that intestinal failure causes. One, you have the GI tract, which is your main source of nutrition, but that is now compromised. Now, malnutrition could be undernutrition, not growing enough, could be a deficiency of a nutrient or a vitamin, which is important to your metabolism. For example, if you're short of vitamin B12, your concentration and moods can be very varied. It's just a nutrient, but you may just have the right body size, but you're deficient in a vitamin. And then also overweight, because we know that overweight can set you up for some chronic health issues like heart disease, stroke, and diabetes. So all these are within the umbrella of malnutrition, and all these are within what we're trying to avoid. And I'll just fly through this for the sake of time. Basically, so brain growth, again, talking about why we do what we do and why pediatrics is different from adults. One, because the first 1,000 days are very critical, okay? And this is from conception to age 2 years. There's a lot that's happening at that time related to the development of brain cells that are going to be important for your sensory context, your learning skills, your speech skills, and your solving problem capabilities. And all those peak and occur within the first 2 years of life. The sensory cortex, which is important for vision, that peaks at about age 1 month or 2 months. Therefore, right at the beginning, you must be providing all the right nutrients. And the temporal cortex, which is important for speech and language, peaks at about 8 months, whereas the frontal cortex, which is important for problem solving and cognition, at about 2 years. So basically, there's a lot of synaptogenesis, nerve proliferation that is supposed to be laid out and in position, preparing you to be able to become a problem-solving adult. Therefore, the strategy in children is that you have to dedicate whatever you're doing to ensure that this development is fully satisfactory. In fact, it takes priority in everything you're doing to ensure that there's adequate brain development in the child. So how do we track that? One, we have a roadmap, and that is the growth chart. Fortunately, we have growth charts available, and these are available for infants and children and adolescents. From birth to 2 years is what they call the WHO growth chart. From 2 years to age 20, there's a CDC growth chart. This is basically one of the most important roadmaps, tools that your physician should have if you have a child, if you're a parent, because that is your roadmap. Because if you're deviating, something is wrong. And therefore, you need to be staying on track, and that's, again, one of the most special issues which I highlight when taking care of children with intestinal failure. Just gonna get past that. There are classifications of malnutrition out there which we use as physicians, and the growth chart uses percentiles, but there's something called Z-scores, and those the physicians use to specifically measure how growth is progressing, because growth in children progresses sometimes in a step-ladder pattern, but you have to be able to determine whereby are you deviating excessively or are you still on track. And there's a tool called the Z-score, which is basically a standard deviation score, which is converted from a percentile and helps you with a better precision track a child's growth. Again, coming down to some of the key things that have to be in place to take care of these children. Again, the Z-scores are important because depending on how severely how low they are, it can predict the outcome. For example, if somebody's growth when converted into a Z-score is less than -3, that is a very concerning sign, because everybody's entitled to falling sick, catching influenza. But if you're malnourished, your risk of a bad outcome, especially death, is very high if your growth parameters are below a Z-score of -3. So everything we do has to bring the growth back on track, and the Z-scores can help you tell you that now you're in danger, you look fine, but just catch something bad and you fall over the cliff. Intestinal failure does impact growth, and we know all that too well. The GI tract is your avenue for nutrition. We have a lot of publications out there. I've just selected a couple which basically highlight the dilemma we have in patients who end up needing intervention like home parenteral nutrition or home enteral nutrition. It's normally because you have to support their growth because they have a disease which left on its own is definitely going to negatively impact the patient's growth. These are data from, the first one is data from the neonatal network, whereby they follow all the preemie infants who develop necrotizing enterocolitis and get surgery and become short-gut, and they followed them over 18 months all over the country. There's a neonatal network, and they did find that even at 22 months, their growth was much lower than that of other children, again showing the significance of this devastating condition or whatever disease that targets your gastrointestinal tract. However, so these bars basically just show, oh goodness, Okay. Show where if 0 is the 50th percentile, you can just see that most of the children are growing way below that bar over there. Okay? But it's not all bad news, because we have data that's now coming out that is showing that actually today, if you compare over the decades, the care of these children is actually getting better, and the outcomes are improving. And the outcomes are improving in that in the decade of the 1900s, the average growth was that low, but it's improving over time. Therefore, there's a better job that's being done. Overall, there's progress, so not all is bad. Nutrient deficiencies, again, have a big insult in children because, again, they are in their period of development, and the time of onset is very, very, it could be just by virtue of the fact that they have the intestinal failure, but others could also be just when they come off parenteral nutrition, because when they're on enteral nutrition and parenteral nutrition, you're guaranteed to receive those nutrients. But when you come off that, that's when you're now left to your own to meet all those needs on your own. And this was some work that was done in Boston that showed that there's a high prevalence of deficiencies when patients come off parenteral nutrition and enteral nutrition. So this is basically one of the big take-homes that I want you to take away. One, the first 2 years of life is very important for very rapid growth. Mainly the brain is rapidly developing in that time, and you have to intervene with all the social resources that stimulate that child, because they have this compromise and they have a condition that impacts their access to nutrients. Therefore, the priority then is to provide the nutrition that enables them to grow maximally, because that sets them on a trajectory to do well, and also you're meeting nutritional needs because there's a lot of growth and nerve proliferation and neurogenesis that is happening at that time. Then between the ages of 2 and about 4 years, your priorities begin to shift, okay? My priorities begin to shift to really make sure that that child gets into a setting whereby their social skills can be stimulated, okay? Because they have to prepare to become problem-solving adults at some point. Sometimes this involves writing letters, sometimes involves using attorneys to be advocates for them. I'm guaranteeing the nutrition, but this is now the priority. So it's not all just parenteral nutrition and enteral nutrition. That is guaranteed, but now the shift has to go to making sure that they're in an environment that is teaching them to socialize and interact with other children. Then between the period of 4 and about 12 years, your strategy in nutrition support is to guarantee that they stay in school, that there's as minimal disruption as possible. If it involves a nurse or a school provider enabling them to have a snack every hour, you do whatever it takes, okay? Because we've got our nutrition down to a good art, but these are the things that have to be in place to ensure that they become successful adults. And then in the adolescent years, you have to be aware that everything you've done can just unravel and fall apart, because there are very big needs for pubertal growth. Therefore, this time the provider, me as the physician, I'm checking micronutrients more aggressively or more intentionally, because I know things that were stable can then begin to fall apart just because they are rapidly growing. Sometimes also adolescents just don't take their medications when they need them the most. So the focus now is really making sure that those needs, proactively making sure that those needs are not deficient. And then after age 16 years, we've completed our growth, and all we have to do is to maintain. So it's a multidisciplinary team of people involved, not just the physician. There are nurses, there are school social workers, there are pharmacists, there are home care workers. Again, we all work as a team to make sure that those goals and that roadmap is being accomplished. Again, there are common issues in enteral nutrition. One of the things again, this audience, I believe you deal with them a lot, is that whenever I would put a G-tube into a patient, I'm always trying to figure out how am I going to take it out, okay? Because it's easy to put tubes in patients, but you have to figure out, if I put it in, what's the exit plan? And that begins from the day you put it in, how you're going to take it out. The priorities vary depending on the age of the patient, but you're providing an environment that will enable that child to come off those feeds when they are developmentally appropriate. Again, there are so many things that happen in terms that affect feeding intolerance, that impact that three-legged stool, vomiting, and all these. I believe this audience here has dealt with one form of them or another. Okay, we are well equipped to investigate all these things that occur, all the impediments, all the complications. We are well equipped to meet them, but we have to think beyond what's the ultimate big picture. One is to get a child to be a successful adult. Okay, so I thought I'll just maybe tail up or wrap up with a couple of do's and don'ts, and these I've got them from my team of work. I have a work with a nurse and a dietitian, and I just asked them, hey, tell me what are the do's and don'ts that you really feel are very specific to pediatrics that I can share with the team, and I believe this audience probably knows a number of them, but I thought they were very interesting. One, as parents of, or as people taking care of these patients, one, always call with questions. Don't wait for appointments. Read labels. Check instructions for flashes and additives. Check for differences between bags. Sometimes we send different bags, we make changes, and people just trust the system. But as families who are involved in children with this condition, you want to be empowered not to just believe everybody has it right. You have to check, make sure what the physician says is what's on the label. Add additives correctly, check infusion rates and so forth. And these slides are going to be, they'll be uploaded and available in case I know this font is pretty small. Again, storage of things correctly, refrigerator malfunctionings. Again, this is just a laundry list of do's and don'ts that empower families of children who are taking care of who have children who have intestinal failure. So really, if I'm to sum up, what are the really important pediatric issues? One, to me, it is, there's a roadmap behind it, okay? The growth chart is the roadmap, okay? The goals of what you do vary depending on the age of the patient. It's a multidisciplinary team that is involved, okay? Sometimes we even involve lawyers, okay? Families are encouraged to be empowered. Check what is shipped to them. Check the nurses who come and work with you. And then I always want to acknowledge the work of Oley because they have a big repository of information that has been very helpful to many people, physicians and other auxiliary staff and families who are taking care of patients on home enteral nutrition and home parenteral nutrition. So that is it. Thank you very much.
Okay, we're going to open up this final session for today with some questions. You can make your way to the mics. And I'm going to ask you a question about the oral rehydration solutions. There have been some with different additives like glycine or arginine or what have you. Do you think there's any advantage of any of the amino acid supplements in those solutions?
I don't know as it's been very well studied. Certainly I think that if people are on parenteral nutrition, they're probably getting reasonable amounts of most of the amino acids. I don't know as it's going to make any benefit in terms of absorbing the solutions. So I don't know as there's necessarily any benefit to adding those additional additives. I don't know if Kelly has any thoughts on it.
You know, I was welcoming. I didn't hear the question.
The question was if there's any advantage to the amino acid supplements in the oral rehydration solutions like glycine and arginine.
Yeah, that's an interesting question, and there are some papers in the literature, I don't know, that do show that that can augment some aquaporins. The very most important thing, though, is going to be getting the sodium and the glucose in the right ratio so that SGLT1 can absorb all the water. But it can lead to, I think, about a 30 to 40% increase from the papers I've looked at.
We know that arginine is actually beneficial from the standpoint of muscle metabolism, and sometimes in our critically ill patients, those things can be of benefit. So in terms of long-term, I think the questions are maybe a little bit, we have, like Kelly says, some, evidence, but not a lot of data out there.
Tim, what about in pediatrics? Ann spoke a little bit earlier this morning, and we had some discussion on the compliance issues in adults with the oral rehydration solutions. Do you find a better acceptance among kids, or what are some of the tricks that you employ?
Thank you. Actually, in pediatrics, I think we are so far ahead of the adults in the acceptance of oral rehydration solutions. In fact, solutions like Pedialyte, unfortunately it was called Pedialyte. Therefore, I don't know whether adults think it's for kids. Maybe they should rename it to something that's more age neutral. But it's always part of the package of what we do. In fact, right from the beginning in our NICUs, they know it's part of the expectation. Diarrhea, fasting, Pedialyte, dilute your feeds. And so it's part of pediatrics. So we haven't had a problem with many of our families dealing with rehydration.
Bob?
I have a question for Dr. Sentongo. We've sort of abandoned growth hormone in the adult PN population because we didn't think it helped with bowel adaptation. But for your growth challenged patients, does it help with catch-up growth, or is growth hormone part of the treatment in children for?
Yes, we have used growth hormone, and again, I think earlier on growth hormone may have been used in the context of, I think, promoting intestinal adaptation, but in terms of growth, it does make a difference. In fact, I have a number of patients who I refer to the endocrinologist because their growth has been so negatively impacted earlier on because we are struggling, and then they are stable, but they are just a big standard deviation shorter than all the other kids. Now, the response is really very variable, and you must make sure that they're getting adequate nutrition, but we do offer it. And some families are usually hesitant because they don't want to deal with another set of injections and so forth, but I encourage it a lot, and I have children on it, and some of them are responding, others are refractory to it, but we do offer it in children short stature.
I think actually it would be interesting to look at growth hormone together with teduglutide, because the growth hormone effects really in humans have never been demonstrated on the bowel, but it increases tubular reabsorption of sodium in the kidney, so it enhances a lot of fluid absorption. But the only concern would be the adenoma risk, because that's increased with growth hormone, and perhaps there could be an additive risk from a different mechanism with GLP-2. But that might be interesting to do. Kelly, the ECHO program, is that, it's geared towards clinicians, but can consumers participate in that? Or?
At this point, the ECHO model just uses clinicians, and so it's not open for participation by patients. But certainly patients can be a very big advocate to get their cases held and reviewed by the ECHO group.
Okay. Or once the clinicians learn how to take care of the patients, then the patients can participate.
There you go. But the patient can certainly ask their clinician to present it. And so that's why I think the website will provide many of you who are interested in that with the information that you can share with your provider.
Any other questions from the audience? Okay, well, I guess that sort of almost put us back in time. Joan's going to come up here. We have some announcements. I want to say a couple of things. I think we had a really great day today. Tomorrow, the weather is supposed to suck in Chicago standards, so try to get all those people that weren't here today to come. We have some lectures in the morning. In the afternoon, there will be roundtables, so almost all the lecturers from today will have a roundtable discussion. So if you were a little bit uncomfortable coming up to the mic in front of the group to ask your questions, you can certainly feel more comfortable in the smaller group. And on top of that, there's more time for a little added discussion, or if you have personal questions to ask or that sort of thing. We do have a wine and cheese coming up where the faculty will be around, and you can talk among yourselves, have a great time. And there's lemonade for the kids too, right?
Just go away. You don't know one thing?
Well, but you don't have your sign. There's no sign that says I have to stop. So I can I keep going? No, you left it there. That's why I kept going.
Oh, run. Here he goes. We got it. Now
All right.
do you get it?
All right, I have to yield now that Dr. Carroll's lifted the sign to Joan.
Okay. I wanted to thank and give a special nod to our AV team, Magic Wig. They've been... Everything ran perfectly. They've been up half the night, or if not all night and all day, trying to make this work, the setup and everything. Thank you so much. They go with us every year wherever we go, in spite of ourselves. I want to thank our speakers, our exhibitors. Oh, take a breath. And especially our audience for the great questions and your major contributions today. The wine and cheese, go out the door and take a right. It's C-D-N-E. Well, no, we're in D&E. ABC, okay. Wine, cheese, and what else do you need? Lemonade. Lemonade, I know, really. A special note, evaluations really are important to us if we're to continue to plan meetings that meet your needs and fulfill your knowledge base. And last but not least, at 7:30 tonight, we're hosting a silent auction. We have wonderful contributions. Exhibitors will be open and at their booth, and that's in Grand Marquis again, and we'll have ice cream truck tweets. Okay, thank you. Wine and cheese next door. Oh. Okay.
No drinks for you. You need to go to the rehydration station. Mark Pooter.